Most people wait until something's wrong to see a doctor. You are not most people. I'm Kevin White. After more than 20 years as an emergency physician, I realized the best medicine is not waiting for the crash. It's helping people stay on the road. This is The Daily Apple, a podcast about living better, longer. Every episode gives you something you can use this week. A smarter habit, a clearer path, or maybe just a new way to think about your health. Because engaged patients are the best patients, and your best years do not have to be behind you. Let's get into it.
Hello, everyone, and welcome back to The Daily Apple. And I'm here with the good Dr. Joshua Schacter. Am I saying your last name right, Schachter?
You are.
Okay.
You're saying it correctly.
I hope I've been saying it right this whole time. Now that we know it.
You have.
But man, I'm excited you're here, and I've been wanting to get you on for some time. And for those of you who don't know Dr. Schachter, you should know him. He is the founder of Pinnacle Integrative Orthopedics and Sports Medicine down in Texas. He is formerly the chief of orthopedic surgery at United Regional Healthcare System, the director of Advanced Orthopedic Center of Excellence, and a conventional joint replacement surgeon for 15 plus years in the past. Now is branded as, your vision has changed. Everything is tweaked, and you've redirected your path, which we're going to dig into. And you're branded now as America's holistic orthopedic surgeon. And we're going to talk about regenerative stuff, dealing with joints, orthopedic issues. And it's just the whole patient kind of situation. I'm there. I've seen your operation. Very thorough, very impressive. You're really making an impact. So I'm just glad to have you on. So thanks.
Thank you, brother. Awesome. It's so awesome to be here with you. So I'm a board certified orthopedic surgeon, as you said. I've been doing orthopedics now for about 20 years. And I was the chairman of orthopedics at United Regional Healthcare System here in Wichita Falls, Texas, which is our local, our like a community hospital, but a large 380 bed hospital. So we did a lot of work, and I was a joint reconstruction specialist. And so as part of that, I became the director of an Advanced Orthopedic Center of Excellence for hip and knee replacement, and I was that for a decade here as well. We were, incidentally, the smallest hospital in history up till that time to receive that designation, so I was pretty proud of that. And, sort of as my career went, I sort of started to get a bit jaded with the approach. We were doing massive amounts of joint replacement surgery, massive amounts of surgeries, and the system, the traditional system as it is, in my view, really pushes us towards surgery. It pays for very minimal conservative therapies that are not terribly effective, and then we end up sort of going down the surgery route. How do I know this? Because I designed a practice to be very busy surgically, and I did about 15,000 surgeries in that time period at United Regional. A lot of surgeries. And so when I came out into private practice, the first thing that I really wanted to change was our approach. How are we looking at the patient through the lens of, more of a functional approach, more of a holistic approach? What are the things that are contributing to our joint pain? Because it's not just that it's a mechanical problem, right? The joint environment can be affected by so many different variables. And through my exposure to functional medicine and then bioidentical hormone replacement therapy options, gut health optimization, we really found an approach that is so effective at treating joint pain when combined with regenerative techniques. And so that's what we've focused on for the last 3 years and have been just amazingly successful. So much so that really my goal now is to prevent people from having surgery if at all possible.
Yeah. That's pretty awesome. So what's, I see this all the time in guys my age and older, and women too. Knees, shoulders, these are active people. They're athletes or weekend warriors and that kind of thing. And they'll go, and they'll start down the pathway of having to have surgery, whether it's, hip replacements or whatever. So whenever you see somebody coming down your path that's in the beginning stages of that, the way you look at them is totally different now. Can you take?
Yeah. Yeah, absolutely. So just to give you an idea of the sort of traditional approach to orthopedics, it's very structural. So we look at an x-ray, we maybe do an exam of the knee, and we're just looking at the structure of the joint, right? So degenerative joint, we do something structural like a knee replacement. Well, the problem, and arthritis is everywhere. There's 32 million Americans that are affected with arthritis of the knee. And 25% of people over the age of 40 will have arthritic pain. That's a statistic that I think is actually a little bit low. It's probably quite a bit higher than that as we age. So there's a huge group of people that really need help. And what we're finding when we dig into some of the causes and root causes is that the joint environment is a biological plus a mechanical sort of structure, right? It's not just the mechanical part that we need to deal with. Like you have a torn meniscus, we go in and remove your meniscus. That doesn't prove effective over the long term. And if you have a degenerative joint and we go in and replace your joint without addressing some of the underlying metabolic problems that could be causing your joint to be inflamed, then we end up with a higher risk of complication. We end up with early joint replacements. And what we found is that, arthritis is really a living tissue problem. It's not just that structural, mechanical thing that we've been taught, both as patients and as orthopedic surgeons. There's so much more to the picture than just the structure. Most people sort of think it's inevitable to have this wear and tear, but what's really happening is oftentimes there's metabolic problems, there's issues with chronic inflammation, even small injuries that become chronically inflamed and cause problems in the future. In integrative orthopedics, we're really trying to get to the root of what's going on so that we can make some changes, both in lifestyle, functional movement, activity, strength, and then do some regeneration for the joint. And it's incredibly effective.
So if you have a guy, say, come to your, gets redirected to you by his own luck, ends up in your office and he's got the early stages of arthritic changes in the shoulder, what's a common thing that you see? And what's your approach? Do you just, obviously you look at him and say, what you're saying is, initially orthopedic, in the traditional sense of medication, we look at the specific problem and we zero in on that, right? You're backing up, you're getting the 30,000 foot view and looking at the whole deal. What's common things that you see and that you'll do in that situation? I know everyone's different, but
so like chronic joint pain really sort of has this predictable triad, right? There's mechanical factors and movement patterns that can lead us to damage in the joint. Right? There's, how you use the shoulder. How are we lifting? What are the specifics of what's sort of causing some of the symptoms that you have? And then there's the inflammatory load. And that's really, it's a combination of what's going on inside the joint, but also it's a systemic problem. So it's what's happening in the system that is making this joint much more susceptible to injury and a pain response. And then there's the tissue capacity around the joint, what's actually going on with the supporting structures around the joint. So when we look at something like a shoulder problem, we want to do a great physical exam, get a good idea of what's going on from a physical exam perspective, and then we want to do some more advanced imaging. So we start with x-ray. X-ray can actually tell us quite a lot. I look like a dynamic study, so I'll perform ultrasound in the office. Obviously, we'll review MRI studies, which will be important, but that really kind of gets us an idea of the joint itself. If we want to really look at what's going on in the whole system, then we want to dig more into sort of a laboratory test. So we look at things like hormone levels. We look at things like gut health. We look at general inflammatory markers. And then we can really see and start to make a big difference and a change in the way that the joint is functioning and working once we start to address all of these different sort of stages of joint inflammation and problems. And putting those all together is what is integrative orthopedics. When we combine local joint-specific regeneration using either stem cells or PRP, and then we combine that with a whole health approach we're much, much more successful. I contend that we really want to spend some time looking at the entire system, right? Arthritis and joint pain is not just a mechanical problem. It is a mechanical problem with a systemic issue. What's causing the joint to become more susceptible to injury, right? We have chronic injury over a long period of time. That's usually from simmering inflammation or some other metabolic contributor. Not just the joint is damaged, right? And when we see a patient in orthopedics, oftentimes we have our patients very well trained that they come in and they expect to have a pill or a single injection or some single treatment that's going to fix them right away.
Yeah.
But unfortunately, these are all very temporary, right?
Mm-hmm.
When we talk about steroid injections in a little bit, we could talk about what surgery does. But if we don't make some changes to the metabolism, if we don't improve the patient's overall health, then we're not going to see as successful a treatment for the shoulder problem. I've had so many people come in and tell me, oh, my shoulders just wore out, it's just done. And then when we dig in deeper, we see that they have chronic inflammation. We see that the joint damage is not actually as bad as the overall inflammatory process if we can get to it early enough, make some interventions before it gets too far down the road, then we can make a huge difference. And we do that every day.
So you're in Texas, I'm in Oklahoma, and the parts of the country we are, the Midwest, the South, there's a lot of garbage, the way people live. Is that something that you tweak and just obviously have to manage dietary issues and get them on a low inflammatory diet? Do you see that kind of makes a big change as you follow these people or what? I interrupted you, so.
No, it's okay. I think so. Arthritis and joint pain is again, it's kind of three basic drivers as I see it. There's this sort of the mechanics of the joint itself, right? Inflammation and the capacity of the tissue around the joint, like muscle and strength and that sort of thing. So when we look at a joint, we want to look at the mechanics and movement. We want to look at how we're using that joint. Is that something that we can optimize? Oftentimes when we have a chronic joint problem, the muscles get really weak. Right? Mm-hmm. That's not always corrected just by pure physical therapy. I mean, it can take 6 to 9 months to actually rehab after a surgery. And in some cases with joint replacement, it could be 2 to 5 years before the patient sort of feels more normal. We want to look really at the inflammatory load. What's going on that's contributing to this joint pain? There's many examples of musculoskeletal pain, shoulder, knee, hip, that are really contributed to by inflammation. And it's not just that you have a arthritis or a rheumatoid arthritis or something like that, right? It can be as simple as you have poorly controlled blood sugar and that causes you to have increased inflammation, right? And you don't have to be diabetic to be insulin resistant.
Right.
Right. So we know that there's so much in the metabolism that contributes. The third thing is how is the muscle, how is the envelope around this compromised joint behaving? Is it working well? Do we have significant muscle wasting? Is that something that we need to work on and retrain? We call it muscular re-education. There's certainly in the physical therapy world, it's a critical part of the process of rehabbing a joint, but I would really like to see that thought of more as the primary way that we take care of joints than just, we're going to do rehab for you after you have a big surgery, right?
Yeah. So what do you say? And I'm kind of bouncing around here for selfish reasons. I just had the Nuvo scan, right? The whole body MRI and saw my shoulders and everything and stuff that doesn't bother you. But the nice thing is it kind of made me think about my joints a lot more. I don't have shoulder problems, knock on wood, that I perceive, but and I work out and all that stuff. But I saw inflammation in both shoulders and I was like, dang. So I'm 51 and we see a lot of guys and girls, I've got, both that have, shoulder problems, this inflammation stuff going on that we're trying to manage. But as you think about somebody getting older, what are some things that you see them doing that's like, just makes you cringe? And we'll just talk about shoulder issues from that time point, or things that people should be cognizant of if they're going to age well and not have premature shoulder issues.
Well, first, I really think we need to be conscious of the biologic system. We just saw that the FDA removed the black box warning from hormone replacement therapies.
Right.
Thank you. I believe that 2 generations of women actually deserve an apology for that. And, as a physician, I'm sorry. I wasn't the one that did it, and I'm certainly the one that's trying to correct it. But gosh, that's a huge mover for joint pain, right? Hormones play a huge role in our joints, and optimization of the hormone axis is critical when we manage joint pain and inflammation. The other thing is insulin sensitivity, right? So we look at other systemic factors. High glucose is inflammatory. We look at the amount of obesity that we have in this country. Fat cells are inflammatory. So the more body weight that you're carrying, the more likely you are to have inflammatory problems. I think one of the biggest things that I'm concerned about, this is kind of one of the things that I like to lecture on, is sarcopenia. So sarcopenia is, and Kevin, but for your audience, sarcopenia is a loss of muscle mass. And this has been directly linked with shortening your lifespan. So when we look at people, and we typically will start to lose some muscle mass as early as the age of 30. And I think a big concern is that a lot of our kids are very inactive. We have more obesity in young people than ever. And so those kids are not building a good base of muscle tissue. And so they're actually starting behind the 8 ball. So I believe that what we're going to see, is even worsening, this problem worsening. Now, the statistic is that we can lose 7, 8, even 10% of our muscle mass per decade after the age of 30, right? So that we end up going into our 60s with 30 to 40% of the muscle mass that we should have. And that's directly linked with early death. Why is it directly linked with early death? Is we don't have enough muscle to protect the musculoskeletal system, then we end up with problems like we have an unstable gait. We're at a higher fall risk. We're at a higher risk for injury to the musculoskeletal system, the shoulders, the hips, the knees. They're not stabilized well by a good muscle envelope. And so we end up with chronic injuries to the tissues and mechanical issues. So in my opinion, sarcopenia is probably one of the biggest drivers that we see of people having problems. So starting early and getting a good amount of muscle mass and maintaining that over a lifetime, keeping your inflammation low by doing things that we all know we should be doing, keeping the weight off, making sure that we avoid processed foods. There's certainly anti-inflammatory diets that we can do. And then making sure that our system is optimized and that we're monitoring it to some extent. And I think whole body MRI is amazing. I wish it was available to everybody.
Yeah.
But simple lab tests are also available to everybody. Simple inflammatory markers are something that you can get from your primary care doctor. And then it can kind of show you where your overall inflammation is. We get surprising results looking at regular people off the street who come in with joint pain. And we see that their inflammatory markers are very high and they don't have a reason for that other than systemic, right?
Yeah. Gosh, you're hitting on all the points before I even ask them. I love it. So these are some of the things you're telling 40 or 50-year-olds to do right now so they're not needing replacements later. Low inflammatory diet, looking at some of these inflammatory markers. I assume you're meeting, high sensitivity CRPs and fasting insulin and all that kind of stuff, which they should get. And actually they can get a lot of it on their own without even a physician. And whenever you go to the gym and you see people lifting and stuff, do you ever cringe and say, oh, he's doing that wrong? Ooh.
I know you do too, brother. So I've been a gym rat for a long time. I think I could certainly, and I'm not meaning to throw rocks, I could certainly do a lot better.
Yeah.
We do see a lot of technique issues. And remember, if we're thinking of joints as not just as a mechanical system that has a biologic influence, right, from the rest of the body.
Yeah.
If we're lifting incorrectly, then that puts a lot of stress along joints. We see it really significant. Shoulders, obviously, knees and hips less frequently. The low back is something that we see injured really frequently with poor mechanics. So when we're able to really spend some time and get good technique, I know Peter Attia really talks about technique all the time. The gurus talk about it, but it's really critically important to make sure that we're using good lifting mechanics when we're doing these exercises. They're super important, but they can be really destructive if we're doing them
let's go into, well, you've already talked about some of these things, but what truly predicts whether somebody keeps their mobility in their 60s, 70s, and 80s, which you probably already kind of touched on?
Well, I think it's a combination of things. So if we want to keep our mobility and vitality into our 60s, 70s, and 80s, just like the modern longevity ideas, we want to start to build that foundation early, right? Because muscle loss becomes such a significant problem. I mean, my mother is 89 years old, and she was a very vital, active, vibrant woman. She rode horses for years. In fact, she actually did a century ride, which is her age plus her horse's age had to equal 100 years. And she rode a 25-year-old horse when she was 75. I mean, she had maintained her muscle up until a certain point, and then she'd had some health issues, and I really firsthand witnessed her sort of wasting, and it's really painful, but it's also very dramatic. We can see in the end of at the latter stages of life, it becomes much, much more important to maintain our fitness and overall health, right? That doesn't necessarily mean that you need to lift super heavy in CrossFit until you're in your 80s. But if we build that base of fitness, at younger ages and then maintain it as we go, that's going to be super, super impactful. And it's going to allow us to live longer, more active lives. Look, we have the tech. I'm sure there's billionaires who are going to live to be 120. Brian Johnson looks like he's going to make it. He seems to be aging backwards. If anybody else has, $6 million a year to spend on their biohacking, you're probably going to be successful as well. For the rest of us, though, we don't need to sleep in a hyperbaric oxygen chamber. We don't have to do, a red light, panel twice a day. We don't have to be super strict about every little bit that we put in our mouths. But what we do need to do is maintain our activity, maintain our mobility, and maintain our strength, right? And this is some pretty common sense stuff. Avoid certain foods that are going to cause inflammation and impact your health. Maintain an active lifestyle, and prevent injury.
Yeah, that's kind of the core of it all, really, right there, which is the lowest hanging fruit you're going to do. You just pretty much summed up. Absolutely. I'm going to shift gears a little bit because you're doing some really cool stuff that not many people are doing. I mean, we've got people that fly out of the country to do stem cells and stuff, but you're doing some pretty cool stuff down there in Texas.
Yeah.
Can you talk about, somebody's joint issues or whatever the problem might be, and you get their inflammatory stuff resolved. You take care of all this other stuff and get them sort of optimized. Then it seems like you move forward with some of these other things before moving on to surgery. And can you comment on, kind of what you guys are doing? Give us some insight.
And the surgeries that I'm most proud of now, I've done some great surgeries, and I still think that orthopedic surgery is one of the most fantastic specialties.
Yeah.
Certainly we're the best looking, but I joke. But I am really excited about regenerative medicine. And the cool thing is, the healthier we have the overall patient, the more optimized they have, the more we move the needle with things like bioidentical hormone replacement therapies and diet, functional nutrition, functional strengthening programs, and those sorts of things, the better our regenerative medicine does. Right now, I use a combination of plasma products. So I use a lot of PRP. And then we also use different fractions of PRP. We use different filters so that we can do platelet-rich fibrin injections. There's all different ways that we can concentrate the healing factors that are in the blood. And then we also use, in combination with that, we use mesenchymal stem cells, which are bone marrow aspirate concentrate. Currently in the United States, I know that there's lots of people getting exosomes, and I know that there's lots of people that are getting like Wharton's jelly and other types of non-autologous or not stem cells that aren't from you, but that's really not approved by the FDA. And so these are things that can benefit us, and it's really exciting technology. But that's stuff that it's tough to do in the United States, and you're not able to do it really legally. We use the patient's own tissue, and studies have suggested that bone marrow aspirate concentrate and PRP are both way more effective than current treatments for joint pain. For instance, steroid injections. I mean, PRP lasts 6 to 12 times longer than a steroid injection. Right? Well done PRP is going to give you great results. Bone marrow aspirate stem cells have about 40 times more of the same healing factors that we get from concentrated PRP. And so it can be extremely effective in healing things like rotator cuff tear and moderate arthritis. And we can do things like treat the bone around a joint by injecting this substance into the bone. It dramatically reduces inflammation. And so we get great results using those options. It's not like a silver bullet. It's really important to understand that regenerative medicine doesn't replace the foundation. I think, and in America, our patients are really looking to come in and have a single solution that's going to fix them like that.
Yeah.
Well, and that's why steroids are so dangerous. And we could talk about steroid injections and why they're such a bad thing for patients, the way that they're done now in musculoskeletal care. When we start to do regenerative medicine, especially when we've optimized the system, especially when we're getting on it early, then we get magnificent outcomes. I mean, we follow our patients for 5 years. And we're at the 3-year mark now, and our success rate is right now over 90%. Mm-hmm. And we have an amazing relief of symptoms. 85% improvement is the average, which is better than a knee replacement in most cases. So we're getting really great results. Other types of injections like hyaluronic acid can be effective, but again, orthobiologics therapies or regenerative medicine therapies like PRP and stem cells have been shown to be more effective. Mm-hmm. And the other thing is they don't damage the system that we put them into because they're your cells and your tissue. Right. So they have a very low risk.
Which is what steroids ultimately do, correct?
Absolutely. Yeah. So steroids are, in my opinion, a real problem. And I'm as guilty as any other orthopedic surgeon of doing many steroid injections in my career. I'm lucky that I feel fortunate that I've seen the light and I really trying to prevent that. But when we do steroid injections, now doing a single steroid injection may help, but the problem is it's really sort of a Band-Aid. Blunts the inflammatory response of the joint and sort of convinces it that there's not a problem. Mm-hmm. The steroid also will damage the tissue in and around a joint. If you inject steroid into a rotator cuff, for instance, there's been several studies that have shown that it increases your risk of rotator cuff tear worsening. Mm-hmm. And then if you go and have it fixed, it increases the risk that your repair doesn't work. And part of the problem is these steroid injections are part of the normal pre-op treatment for a lot of people. And so a lot of people are getting steroid injections and then having surgeries that fail or have complications because they had that type of treatment. Yeah. So steroid injections in particular are bad. We've been doing them since 1949, and we've known since about 51 that they damage tissue. They're specifically toxic to chondrocytes or the cartilage cell, right? Specifically toxic to fibroblasts or the cells that are in the tendons. So that's
cartilage damage and regression is the big problem here in the long run. I mean, you made a good point. I guess it needs to be said again. It decreases the inflammation of the joint, which is why people have less pain for a period of time afterwards. But at the same token, you're diminishing your cartilage, and so there's a price to pay for that. For sure. But so you're saying a better option if someone was to jump to that would be to inject, say, PRP or something else like what you're talking about.
So the better option is to avoid steroids altogether. Right. There was a study that was done back in the teens that showed that serial steroid injections, so if you had more than 2 in a calendar year, it progressed your arthritis by a notable amount. Yeah. So we have patients that have been through a series of steroid injections every 6 weeks or 3 months. Now, the standard is we're not supposed to do them any more often than 3 to 6 months apart. Mm-hmm. But oftentimes we'll see, doctors doing or providers, clinicians doing steroid injections much more frequently because they want to help people. I don't think anybody's really out there like, I'm going to give you a steroid injection because it's going to speed your, it's going to speed your joint degeneration and cause you to have osteoporosis and all these other problems.
Yeah.
I think we honestly in medicine want to help. And steroid injections are one of the most devious treatments because they're effective pretty quickly.
Yeah.
And so you get to do this injection. The patient feels better pretty quickly.
Problem solved.
So you feel like the problem's solved. They leave your office. They're super happy. You get to be happy. But the problem is we're just sort of kicking the can down the road and we're making the problem worse as we go.
Mm-hmm. Back to mesenchymal stem cell therapy. Everything is pretty dialed in down there. People think, oh, that probably hurts taking my own bone marrow stem cells. But as you guys showed us, so it's not that big of a deal.
No, it gets a bit of a bad rap. People think bone marrow biopsy. And my oncology colleagues, I love you guys. You're saving lives. Thank you for doing what you do. Why can't you numb up the bone when you do those? Like, you've given us such a bad rap. People are like, oh my God, my aunt had a bone marrow biopsy for, breast cancer or something. And she said it was miserable.
Yeah.
I don't know how you make it that miserable. We have a system that we learned from Donnie Buford, who's the president of the Interventional Orthobiologics Foundation. Now he's down in Dallas. He's amazing.
Yeah.
And he taught us a technique that is relatively pain-free. We can also do a little bit of sedation if patients desire that. We do sedation for certain types of procedures. It's really, not uncomfortable. I had, like everything that I do in my office, I do it on myself first, or I have it done to me first. So I was the first bone marrow aspirate concentrate patient.
Really?
And I will tell you that it is, I have a left knee arthritis and it's early and moderate. And so I've been doing everything I can to prevent problems in the future. And it's, incidentally, I haven't had any pain in that knee for over 30 months at this point. So we did one of our joint treatments and it's been amazing. But when we do the harvest, we numb up that area. We go and we draw the bone marrow off with a small needle. Most of our patients are awake and speaking to me.
Uh-huh.
And we talk them through it, and then we process the material and we inject it back in. Bone marrow aspirate concentrate to me, it's a really magical substance. It is less inflammatory than PRP. It's very effective in the long term. It's been shown to be quite effective for 24 months or even in some studies 6 to 10 years. And it's just one of those procedures that I think needs more doing. There's a lot of benefits from these kinds of procedures.
Do you inject those in the shoulders, in the knees, in the hips as well? Or no?
Yeah. So when we do regenerative procedures, oftentimes we'll start with PRP or we'll use PRP as an augment. One of the cool things about platelets is they have a bit of a targeting function, right? So a platelet can actually tell stem cells or cells what to do. Mm-hmm. And so we put that in first, and then we'll put stem cells in after we do platelets. Either we can do it at the same sitting, but we typically will space it out. So we'll do a joint treatment and then we'll come back depending on what we're treating between 2 and 6 weeks later to do the bone marrow. And those cells together seem to be more effective.
Yeah.
When done in series. But we inject, it's great for shoulder. We can't really say that legally we can't say that we're regenerating anything. The FDA really frowns on that.
Yeah. But
it creates an optimal healing environment for the joint. Let's put it that way. And pretty incredible things can happen. We use it in the shoulder. I love it for partial thickness rotator cuff tears. So that patient that you see, I have a guy that came in and he'd had probably 5 years of shoulder pain. We get an x-ray and he's got a big old piece of calcium that's in his rotator cuff. That's called calcific tendonitis. John wanted to avoid surgery at all costs. And so we did a series of injections. We actually took out the calcium using a needle with him sedated. And then we injected it with a series of PRP and bone marrow. Within 3 months, that calcium deposit was completely gone. He's pain-free. It's been almost 18 months now. I just saw him in the office.
Yeah.
And he's doing incredibly, so happy. So in the knee, these treatments are really good for things like arthritis. You can be past the point where regenerative therapy is going to help you. When are you past that point? Well, when you have a mechanical problem. So when the joint becomes very crooked, right? Mm-hmm. But in the earlier stages of arthritis, these treatments are really effective and can last a very, very long time.
Yeah.
And in the hip, we do the same thing. We inject directly into the hip joint. In some cases, we'll actually take and inject that bone marrow cell matrix into the bone around a joint. This has been really well studied in the knee. There's a French doctor named Hernigau who's done a series on this. And it even compares when we inject that, even for end-stage arthritis, more severe arthritis, injecting the bone around the joint can be more effective than just injecting the joint itself.
Can be more effective.
And last longer, yeah. More durable results.
Dang. Okay. Okay. Awesome. Well, I need to get down there and do some injections to stay ahead of myself. But so, I'm going to shift gears because I want to be respectful of your time here. I know you got some stuff going on, but where do you see orthopedics going? Where do you see this deal moving forward in the future?
I see integrative orthopedics and regenerative medicine as the absolute future of musculoskeletal care. I would love to see a future in which we do many, many fewer joint replacements. Look, there's about 35% of joint replacements done in the United States are done prematurely, meaning that the joint is not completely end stage, right? I myself did joint replacements even on moderate arthritis because we had exhausted all conservative measures. So we tried a steroid injection, we sent the patient to therapy, they still had pain, right?
Yeah.
That's really unfortunate because now, since 2008, we've seen an over 200% increase in hip and knee replacements in young people aged 40 to 55.
Yeah.
This, those people are actually slightly increased risk for complications like stiffness and early joint wear, even infection. And because those patients aren't necessarily in their healthiest state, they're coming in with other medical problems because they're American. Mm-hmm. And we're seeing problems with joint replacement surgeries. So I would love to get to these joints earlier and see the standard become, we have you come in, we do metabolic work, we work on the joint with regenerative medicine, and we don't have to go to joint replacement.
Right.
We don't have to go to degenerative type joint surgeries like a knee scope for a meniscus tear that's, in the setting of arthritis. Because a lot of these scopes that are being done are not effective, right? They're not effective in the long term. They don't change the outcome of the joint other than to damage the joint a little bit further. So in my opinion, the sorts of things that we're doing in regenerative medicine, in integrative orthopedics, in functional medicine are really the future. This is where it's going. And I think in 15 years, I hope that we look back and say, oh my gosh, I'm so glad that we don't have to do this many joint replacements. Now, here's the problem. There's a lot of pride involved in orthopedic surgeries. Talking orthopedic surgeons out of doing orthopedic surgeries that's a big ask because we're trained to do surgery. A lot of us love it. It's also fun sometimes. But I think, in the setting of taking the best care of people, early surgery and rushing people to surgery is not the best option. If we look at the traditional system, it is built to bring people to surgery, right?
Yeah.
And because we're getting less and less, surgeons get paid less and less by insurance companies, they need to do more and more and more.
Right.
And so we're really seeing hospitals, specifically hospitals that employ surgeons, are really pushing more and more surgery. Orthopedic surgery is one of the more profitable product lines in a hospital. And I saw that in my employment. It went from being a good partner with a hospital to being, hey, we need you doing more and more of this. We need you doing more and more surgery, and we're going to set the practice up so that it really pushes patients to get surgery earlier. And I think that's a shame.
Yeah, that's where the money is. But yeah, that's it. You kind of summed it up with, exhausting all measures prior to surgery. That alone will, I think, change to be more regenerative medicine prior to the surgical option.
I totally agree.
Yeah, that's the way it should be. I love what you're doing. I don't want to rush you out of time, but before we go, I do want to hear about Egypt, because we were going to do this. You were going to be in front of the pyramids, but instead of that, just in front of some family pictures on the wall, which is beautiful. How was that trip? I haven't talked to you since then. You guys were just over there hanging out.
Yeah. I think one of my greatest joys, my wife loves to travel.
Yeah.
Amber's also, this whole functional and integrative orthopedics idea, is sort of a synthesis of how my wife views her health.
Yeah.
And what she would like to see. She's a BRCA patient, so she has the breast cancer gene.
Okay.
And watching her get 15 plus surgeries over the last 10 years and how she was treated really drove us to try and find a better way for our patients, right? And so a lot of her ideas are in Pinnacle. And she happens to be the CEO of our company. So she does a lot of direction. But she loves to travel, and we love to go and see and get new perspectives. And so we had the opportunity to go to Egypt, and we basically flew to Aswan, which is in the south of Egypt, and we sailed up the Nile. And it was actually a retreat. We could call it a mindfulness retreat. It was a meditation retreat. And so basically we were working on techniques, mindfulness and meditation techniques, the whole time with a really amazing meditation teacher named Emily Fletcher, who's a great friend. For anybody who's interested in learning some mindfulness and meditation, she has an amazing course. It's called Ziva Online, and she teaches you how to meditate 15 minutes a day. It's a 2-week course, and anybody should mindfulness is a huge driver in our health. And if we can slow down and take a minute to be present, it changes everything about our chemistry. I even, talk to patients about mindfulness when we were doing regenerative medicine. So that's what we were doing there. We were really studying mindfulness and how we can integrate some of these techniques into what we do here at Pinnacle. And then, of course, we got to see the pyramids. We got to spend some time in the pyramids. And then we spent a couple of days in Cairo. If anybody ever gets a chance to go to Cairo, it's a city of 20 million people, so it's tiny. It is exotic and amazing. Egyptian people are beautiful. And then we actually went to the Red Sea, where I did some kiteboarding. I've been kiteboarding around the world since 2015. I really great. I think travel gives us the opportunity to see so many other alternatives to our own regular everyday life. Mm-hmm. Right. I think my travels and the activities I've done and the things that we've done together, Amber and I, have really given us the opportunity to have a new perspective on how we take care of people here in the office and how we want to execute taking care of joint pain patients. It helps us to think out of the box. It helps us to learn new ideas. It helps us to explore some ways to optimize our own health so that we are in a peak state when we travel. And that's a lot of what we do when we travel. We do anti-inflammatory diet, we do IVs, we do peptide therapeutics. There's a lot of things that we do to maintain our health while we're traveling. And then we bring that back to Pinnacle and we share it with our patients.
Well, you've got a cool perspective. I love the way you live. I know whenever I first met you, kiteboarding and, doing, paragliding all over the world, showing me pictures. Yeah, you live a great life. That's super cool. You're doing cool stuff. And I'm glad to know you, man. Very cool.
Ditto.
Where do people find you? Because they need to find your Instagram to look at some of these pictures you posted.
So you can see at Dr. Joshua Schachter is my Instagram handle. Pinnacle Integrative Orthopedics is the search that you'd want to do on Facebook.
Yeah.
Pinnacle Sports Medicine or Pinnacle Integrative Orthopedics will take you to our website. And then, of course, you could give us a call, 940-285-5007. I've got a YouTube channel. It's at Dr. Joshua Schachter. There's plenty of material on there. You could see some patient experiences from Pinnacle. You could see some of the ways I do, a fair amount of content on what I think about it, how I approach what we do. And so you see some instructional videos on that as well. And come stalk me.
Yeah.
Check me out. It's at Dr. Joshua, JOSHUA, is the Instagram. And you can look us up at Pinnacle Integrative Orthopedics. You can search that on Instagram and Facebook and TikTok. And it's all there.
Well, cool. Dude, thanks for making time. It's
my pleasure
to talk to you, man. And anyway, enjoy the rest of your day. And everybody, thanks for listening. And anyway, see you guys later.
Awesome. Thanks, Kevin.
Goodbye. Before we wrap up, I want to leave you with a few things you can take into your own health plan. These are the big ideas I hope you carry out of this conversation. When you think about joint pain, I want you to stop thinking only in terms of wear and tear. Your shoulder, knee, or hip is living tissue in a living system. If you are dealing with joint pain, ask your doctor, can we look at my whole system? Hormones, insulin resistance, inflammation, and muscle mass. Not just the joint image. What labs can we run to understand my inflammatory load and metabolic health? You are not just a bad knee. You are a whole person, and your joints are telling you a story about the rest of your health. If this conversation was helpful and you want more practical tools for living stronger and longer, make sure you follow The Daily Apple on whatever podcast platform you use. If you have a second, dropping a quick 5-star review really does help more people find the show. And if someone in your life is dealing with joint pain or facing a surgery decision, send this episode their way. And if you want to learn more about the kind of testing, labs, and regenerative options we use in our practice, you can always visit www.primehealthassociates.com. Thanks for listening.